This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is a modern take on old school medicine, allowing doctors to reconnect with their patients on a personal and more even playing field, a mutually beneficial relationship, and to truly address the matters that are important to both. My name is Michael Chun of Chun Family Medicine Direct Primary Care, and this is my DPC story.
Dr. Michael Chun started his path in healthcare as a phlebotomist at the University Hospital in Little Rock, Arkansas. The energy of the hospital and a deep interest in science directed him to a career in medicine. In a few short years, he was a student in that same hospital, and he graduated from the University of Arkansas for Medical Sciences in 1998. He completed family medicine residency at Miami Valley Hospital in Dayton, Ohio, serving as co-chief resident in his final year of training. Dr. Chun first practiced in Benton, Kentucky in both inpatient and outpatient settings in a rural community, then transitioned to occupational health and emergency care. In 2007, he and his family moved to Cincinnati to start Chun Family Medicine. Initially a part of Premier Health Partners, in 2016, Chun Family Medicine became a fully independent practice, taking a step away from corporate involvement in the doctor-patient relationship. In January of 2022, the DPC model was introduced to Dr. Chun by a longtime colleague. The idea of returning to the foundations of medicine became a growing preoccupation, and with the support of colleagues and his family, Dr. Chun decided to transition Chun Family Medicine to Chun Family Medicine Direct Primary Care in January of 2023. Dr. Chun has been married to Andrea since 1995. Together, they have raised 3 amazing adult children. Most of the credit goes to Andrea, though. Scattered across Texas, California, and Arkansas, Hannah, with her husband Josh, Isaac, and Caleb, aka the Chunlings, are creating lives of their own out of the nest. Copper, the mini golden doodle, keeps the house alive with walks and fetch. Faith and spirituality play a significant role in Dr. Chun's life. Dr. Chun dabbles in woodworking, loves baseball, go Cardinals, attends live music and theater, and enjoys a good show on TV or the big screen. He and Andrea have been dubbed foodies by some of their friends and love the food scene in Cincinnati, Ohio. Welcome to the podcast, Dr. Chun.
Thanks for having me.
I love that your journey has truly demonstrated that you've continued to hone in even further to that patient-doctor relationship. And so I want to start off with your journey into medicine was not going to medical school after undergrad. You were actually a phlebotomist before you became a physician. So tell us, the listeners and myself, how did you end up going into phlebotomy and how did that lead to you choosing to become a physician?
Sure. I was a college student studying. I think at that point I was a biology major and I got a phone call. My dad worked for the American Red Cross and was friends or colleagues with the blood bank administrators in the local hospitals. And he called and said, get up, you have a job for the summer. There's a guy down at the university hospital who's in charge of the blood bank. You're going to be a phlebotomist. I'm like, okay, I don't know what a phlebotomist is. So go to the hospital, and they said, well, you're going to draw blood from patients. And once again, okay, you're going to have to show me the ropes. So connected with several seasoned phlebotomists, and they showed me what to do. And I did that for, well, through college and all the summers and all the holidays. It allowed me to work nights and weekends and holidays. And I just love it. I loved it. I fell in love with the energy of the hospital. It was the university hospital where all the teaching and all the trauma and all the action happened. And the University of Arkansas is the state's only medical center, or at least it was at the time, medical school. And so all the residents and training was happening there. And I just loved it. I loved the mysteries and the weird things that came in. And I got to kind of be a fly on the wall as a phlebotomist and learned a good skill. And it changed my direction. I was thinking about being a pharmacist or a chemistry teacher or whatnot, and just wasn't quite sure what to do. And this really hooked me.
I love that. I love that the journey was get up, you got a job today, man. That is amazing. And that's so, I don't know. I think it speaks to our parents in this idea that a lot of us come from, there's not necessarily a set path. It's just, hey, this opportunity is here. This is something you can take advantage of. And I absolutely love that it has led you into this journey and into now being a direct primary care physician. So when you decided that medicine was the way to go, you saw these cases, being the person in the room without at the time being the person to triage and to diagnose, et cetera. When you eventually went into medical school, how was medical school different for you because you had had that experience versus someone who had not even been in a hospital or a clinic before applying to medical school?
That's interesting because many times, this was back in the 90s, we had little white lab jackets as phlebotomists. And so we kind of looked like medical students anyway. And I got mistaken for a medical student or a resident many times. And I'm like, wait a minute, I'm not the doctor. I need to go get a doctor. And then as the medical student and then resident, I was familiar with the rooms, the way the rooms were set up. Okay, don't bump into that. Don't unplug that machine. So that was a little bit of familiarity. And then the whole mystery of ordering labs, I knew, I was like, oh, you need to put this in and make sure you order it with this add-on, or this goes in the wrong, you put that in the wrong tube. And that was really, really helpful for sure.
That learning curve was so less steep for you when it came to
Right.
especially the labs. And I love that because the first part of your journey after going to medical school in terms of really practicing was both in an inpatient and outpatient setting in rural Kentucky. So given that you had this experience in the medical field before medical school and you were able to build off of that in training, what was life like in Kentucky when you were in a rural environment practicing medicine?
Yeah, Benton, Kentucky, far western Kentucky is very blue collar area. A lot of manufacturing, a lot of tire manufacturers, chemical manufacturing, some metals and alloys type thing. And so a lot of my patients were hardworking, very physical jobs. We also were located in the corner of the state there that connected Missouri, Illinois, and Tennessee. And so this was the height of the OxyContin and hydrocodone stuff. So there was lots of doctor shopping. So people could drive to all four states in a day and hit four doctor's appointments and probably have a 500 pills of Lortab or oxycodone or whatnot. So that was very, very challenging. Casper and the electronic reporting technology was just getting started. We sent faxes in when we had to check people's prescribing patterns and such. So that was definitely a trial by fire, and I did not enjoy that at all. That wasn't my training to pass out narcotics at all. So very, very challenging and kind of disheartening at times. But then on the other side, you treat someone on a Christmas Eve that they're leaving on vacation. It's a little rural town, and they bring you a warm banana pudding when they get back in town for thanking you for taking care of them. And that hospitality, Southern hospitality and gratitude was there. So the trade-offs were it was really nice place to work, but it was in a setting that different than the urban setting of my residency and medical school training, for sure.
I'm with you 110% when it comes to that rural hospitality. There's nothing like it. When it comes, though, to the culture that we're in now, where physicians are really commodities, we are not valued as people who are trained to think and diagnose and be all the things, especially in family practice. When you were practicing in this opiate world that you were in, especially at the confluence of all of these geographic areas, did you have any sense that you were valued any less as a physician because you were the one with the prescription pad, or did you still feel valued apart from the patients with the banana pudding by your employer?
It felt like a target at times because it was a game to get how can I get the prescription out of the doctor. So that part of it was felt undervalued because I wasn't playing the role as a physician. I was the kind of the guardian of the pad versus the right prescriber. I do feel like those who were legitimately being treated for their healthcare and needed that healthcare did value a conscientious, well-trained physician who could, provide the services that they needed in a rural area, because Nashville was 2 hours away. Paducah, the next biggest town, which was about 70,000 people, was half an hour away. So there was a lot of driving involved if you needed to see a specialist. And if you were well trained, and I feel like I had a great residency training, you saved some people some time and some time away from work, time away from home, dollars on gas driving places. So
At what point did you make the transition into your next step along your journey where you were doing occupational medicine and emergency medicine before moving back to Ohio? Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes.
yeah, the practice that I started in, the growth there was starting to falter. We weren't quite sure if we were wanting to stay in the rural area long term with our family. And this occupational medicine opportunity came available, and I did have a non-compete, so I couldn't just open another family practice office down the street in our small town. So the occupational medicine bit of it was outside of that restriction. So it was a good fit. It was great timing. It was a different aspect of primary care that I had not been exposed to any great degree. And at that part, it was fun to learn. It was I got my own hard hat, so I could go into the plants and go see where these people worked, and it really opened my eyes to the real cause and effect part of especially musculoskeletal medicine, but other exposures. There was a plant that made polyvinyl chloride PVC, and that one of the byproducts is chlorine gas. So there were these chlorine gas tanks on plant, and the next plant down the street had made what's it called, the Freon for your air conditioners, and they had fluorine gas, and it was our little area was on the Homeland Security map because if you blew either of those up, the area around was going to really be toxic. So that was an exposure to different part of medicine for sure.
How did you work that time in to do site visits and to see, on the job what people were going through? Were you under a contract that included payment for your time to go there? Was there an RVU? I mean, and I ask that in all earnest because there's walked into a lamppost as an ICD-10. So
Yeah, right.
how were you able to see patients, but also see them in such a personalized manner back then?
I was an hourly employee for a service, employee health service that contracted with the individual company. So we provided pulmonary function testing, hearing conservation, minor emergency care, and their pre employment and then workers' comp type services. So that was part of my job, was to go visit with the safety directors and sometimes see workers on site. Most of the time they came to our clinic that was in the area and was very accessible to them. So it was just really helpful to walk around. And I was a chemistry major, so I saw these 4-story tall buildings that essentially was a big Erlenmeyer flask or a big beaker that I messed with in college chemistry. So it was, I liked it. I kind of geeked out on that kind of thing. So it was fun.
And at what point did you transition to doing emergency medicine, or was that overlapping with your time doing occupational medicine?
That was more of a like a moonlighting type situation. The local critical care hospital that I had done the inpatient medicine with, I continued to be able to do inpatient medicine. So I would admit patients. I was on the call schedule for our critical access hospital. So I did emergency room shifts. It was a small hospital in a rural area. We were pretty close to Kentucky Lake and Lake Barkley, which is a big recreation area. So we saw four-wheeler accidents and snake bites and fish hooks in the thumb and sunburns and such in the summertime. And yeah, on top of the elderly person who fell and broke their hip, or the 65-year-old smoker with pneumonia. So it was a broad range of things, but in a very small community.
Gotcha. Now, when you guys decided to move back to Ohio, I want to ask, what was the what was the reason for moving back specifically to Ohio? And how did you then find a job, given that you were in a location where you had been before training in medical school and residency, but then not necessarily for the years prior to moving back to Ohio?
Right. Yeah. So once again, just kind of like, is this all there is? And I don't say that in a derogatory way, but just in my own journey, thinking I wanted to practice more full scope family medicine. I trained at Miami Valley Hospital in Dayton, Ohio, and my residency mates were all working kind of spread out. And Dr. Timothy Linker, who I mentioned in my alluded to in my website, had established his practice, was getting busy, and I contacted him, said, "Hey, what's going on?" He goes, "Oh, it's interesting you call. I was just thinking about expanding our practice here, and with Stark laws and a lot of the practice arrangements, he couldn't subsidize my startup, and so I became an employee. It worked out. My wife's from Cincinnati, and so it's a familiar area. We liked the size. It's a middle place, as they say on the show The Good Place. It's kind of a middle of the world, middle of the country kind of place. And so I became employed by a corporate hospital system here in town, and we became a joint venture. So I essentially rented employees space, supplies, and all the things that it took to have a practice from him. And we had an arrangement to do that. And I had my practice that was run by the hospital, and he had his practice that was solo and privately owned.
When you talk about renting, did you get to participate in choosing staff or billers, et cetera? Or did you get, these are the people you have to choose from, that's all you got?
I had probably the best employed experience. My practice was the farthest south in the practice area for this hospital system. We kind of were a guinea pig, and are they going to be able to break into this zip code essentially? And they were very hands off. They just said, "Yes, we'll fund your salary. You just see patients, make money, and we'll be fine." So I had a hand in hiring and firing and capital expenses and all of those things. They didn't even really push like referral patterns or anything. It worked as a great relationship until meaningful use came out. And we're in an interesting area. It's very much a suburban kind of bedroom type area for Cincinnati, very middle class, upper middle class probably, and we had very, very few Medicare patients and very, very few Medicaid patients given our geographical location. And so we really struggled to meet the criteria to submit data for meaningful use. So that whole process, I was kind of the annoying practice in the group that, oh, he's the problem child because he's special. And we were allowed to keep our EMR that pre-existed Epic. And they said, yeah, because you're kind of on the outskirts, we'll let you keep it until you can't. And then 2016, they said you either have to transition to Epic or not. And Dr. Linker is privately owned. He doesn't want to go on Epic. He has no reason to be on Epic, and we're not going to have two EMR systems in our one little office there. So I said, well, now's a good time to part ways. I don't have a non-compete. It just basically changed the sign on the door, and the next day we opened as Chun Family Medicine.
It's definitely a rarity to hear something like that happening these days. I also will give a high five to all the other people who laughed when you said meaningful use and thought meaningless use is what you said. So going on to that thread, it's incredible how I can see the seeds of DPC blooming in your mind just because it's I'm supposed to be a doctor, and this is an absolute barrier to me having my relationship that was there with my patients because it's now one more thing that you have to do. I think of that graph that is very famous where it's every time there's a meaningless use type of requirement, the number of admin hours goes up and the physician satisfaction plateaus or goes down like somebody
Right.
diving off of a diving board. So when we talk about you having this amazing like day zero, you were at your previous practice, and then day one, you were Chun Family Medicine. Going into that transition, though, I mean, you have a logo and you have a website, and your website now is updated to your Chun Family Medicine Direct Primary Care. But at the time, I mean, did you just like whip that logo out and posted something on the door the next day, or had you been sensing that this change was going to come so that you had to make a switch?
We did have some time, fortunately, and without the non-compete, we could work on credentialing with changing my NPI or whatever numbers needed to change to practice independently. And my logo, which is the same logo that I have today, a friend happened to have he's not even a graphic designer as by trade, but it has that interest. And I said, let's sit down and hammer something out. And so he came up with a bunch of different options, and we refined it down. And yeah, it's really very DIY, and I haven't hired big ad agencies or marketing groups or anything. It's been friend of a friend or that type of situation. So yeah, definitely the DPC was a complete rework of the website. Just I couldn't even imagine trying to do code. So I went the easy route on all that.
When you made the transition for your patients, because you were still at the time accepting insurance, was there any, I mean, did they even get that there was a change at all? Or, I mean, clearly the name had changed, but in terms of like how they experienced your practice as a physician, the relationship that they had with you, did that change at all when you went from your previous practice to Chun Family Medicine?
Really not, because this was the beginning of, well, our practice had not yet turned over the keys of the billing to the big corporate office. So they still got statements directly from my office, and they still got phone calls from my employees as far as your bills past due, or we need to update your insurance card or whatnot. So they really didn't see a difference. And unfortunately, the money really didn't change a whole lot either as far as how I got paid. I had to see the patients to be paid. It wasn't just a base salary anymore. And so the productivity, that mindset was still there. It still was, hey, I need to keep my schedule full in order to be able to take home enough money to pay my mortgage and kids' expenses and things. So that part of it, unfortunately, didn't change a whole lot either, because we really didn't have a contentious relationship with the hospital system at that point. So I wasn't really running away from, I just can't take it anymore kind of attitude. That is the attitude I had leaving insurance to DPC, though.
So let's go there, because from 2016 all the way until 2022, I mean, you were living that life of the fee-for-service doctor. What changes did you see over time that got you to this point of, I am so done, I'm doing DPC? Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited, customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
I mean, you could never take vacation without doing the mental math of, okay, I'm gone so many days, which equals so many dollars I'm not going to earn. And then I'm going to pay money to go on vacation. So this vacation is a net loss. Anytime I took time away, that grinded on me. The hiring and firing part of it still is there today as a DPC practice and privately owned practice. So that really didn't change. But being beholden to the insurance companies and knowing that I was never going to get a raise per patient, that dollar figure is probably never ever going to go up. And employee wage costs are going to go up. The supply costs are going to go up. My rent is going to go up. And there just was an outlook of the only way I'm ever going to make more money than I'm making today is to see more patients, which is already a strain and a source of dissatisfaction for me and my patients.
Absolutely. And I think about when patients get the brunt of that, it's, well, I couldn't see my doctor, so I sat here with a hematoma that went septic and opened up the skin all the way down to my shin. I mean, crazy things are happening because it's like we have too many patients on our panels in fee-for-service, not in DPC, where it really accessibility is like the hugest problem that people see when they're, I mean, even trying to call into an office and they're like, no one will pick up. I literally, and I'm sure you do now, like I have patients saying, I need to get scheduled with said doctor, surgery, cardiology, whatever, but I can't get them. So I called you. And I'm like, okay, you still need to see them, but how can I help? Maybe they'll talk to a doctor. I don't know. But it's crazy to hear that and then to envision what our patients go through, which is like completely unacceptable. I mean, it's unacceptable for us as physicians because we're under that pressure when at the root of all of this, we're trying to be doctors. There's people who say like, it's not the doctor that's the problem, it's the system. And that is definitely true in a lot of cases where you have no control over your patient panel or how many are on your panel. And so it's very interesting that you had seen this transition again, going from your days as a phlebotomist to really wanting to be in the medical world as a physician, and then seeing this transition just continue to take hold to this place of you have to pay to go on vacation. I mean, residents still, they don't believe they're like, I mean, their faces, their jaws drop when they hear these stories. I mean, the local corporation's tactic when CMS raised a reimbursement for primary care RVUs was, yes, that all of that money goes to the corporation. And so of that newly increased pool, we're going to take this amount and magically you're getting less than before CMS raised the rates. And they're like, wait, how does that work? How is that fair? It's like, oh, it's not fair. It's just, that's fair. That's just how it happens. So let's go to your journey now. Back in 2022, just a year prior to opening, you had learned about DPC. So tell us about how you learned about DPC and how quickly did your mind change to fee-for-service is no longer going to be my plan?
I was feeling the strain mental health wise. I was having anxiousness and probably some form of depression with just kind of hopeless feelings of the career, and physically tired, physically high blood pressure, high cholesterol, overweight. Just, it was not good. I was not doing well. And kind of had that same scenario when we moved from Kentucky to Ohio. Another resident friend called from Oxford, Ohio, Dr. Jason Hoke, and said, "Hey, have you heard of direct primary care?" I'm like, "No, I don't know. I've heard of vague concierge, whatever." And he goes, "Hey, let's go to dinner and let's talk about it." I'm like, "Okay." So the original pitch was for me to join him at his practice in Oxford, which is about 45 minutes away, about an hour from my house. Um, and I'm like, wow, this sounds amazing, but I can't drive an hour. And we had just bought a house and built a house, bought a house, whatever. And I'm like, I'm not going through the whole real estate thing, but I like your idea, and I would love to be your colleague in spirit. So we had a lot of brainstorming sessions. I went to the DPC summit in Kansas City. And first time I had seen you on stage and introduced to the podcast, and it was the proverbial fire hose. And every night I would come home from the conference and talk to my wife, and she's like, "Wow, it sounds interesting and sounds like it answers a lot of our questions and a lot of the needs that we have." And it just clicked. And by the end of the conference, we're driving home from Kansas City to Cincinnati, and I'm like, I think I'm feeling like we probably ought to do this. And she supported it, which is huge. I mean, I can't make a big job move like this without her support and her being on board. So we're like, okay, we're going to do this. So I listened to every podcast that you put out. I listened to I think the direct primary care podcast that Rousseau had on. I listened to all of his stuff, and I didn't really read a lot of stuff. I knew enough about doing a practice that I just needed to know what a DPC practice looked like. So listening to everyone else's scenarios and stories really, really helped me flesh things out. And then talk to Dr. Hoke and then Dr. Amy Meckley down in, she's just south of us, and talked to her a lot and got a good sense, and then had some kind of focus type questions to patients. Hey, if I did this, what do you think? And some people that I trusted would give me good feedback, and it sounded like it would fly. So let's see, the conference was in June. I think in August, I sent out my first MailChimp email, and the phone started ringing like crazy. "What do you mean, Dr. Chen's blah, blah, blah," and all this. And so then probably every patient visit, September through December, the last 5 minutes of every single visit was, "Oh, so what does DPC mean for me? And I have insurance, or I don't have insurance, or my employer already pays for all this stuff." And I got to answer all the bullet points, all the talking points that you and all the other DPC docs on before me had fleshed out. And so I had a sore throat pretty much every night coming home, because I talked twice as much as I ever did. And then building a website and talking to everybody about their different communication platforms, membership management, and all the stuff. So we got it all lined up ahead of time, which was great. Started pre-enrolling, I think, in November of 22, and then January 3rd, I think, was the Tuesday after the holiday. We opened the doors as DPC.
What a way to celebrate the new year. That is awesome. And I love just going back to, you had talked with Dr. Linkler and heard about doing private practice under a fee-for-service model because DPC wasn't as prevalent. But when you talked with someone like Dr. Hoke, who was already doing DPC, that's what I love. And I'm so glad that you found the podcast, you found Dr. Roussel's podcast, that you were able to find things out there that were able to help you along your journey, as well as going to the summit. But I think that this is what I love also about this movement, that if somebody is looking for a different way to do things in their second year of residency or their third year out of residency, there's people like yourself who they can turn to say, "Hey, Dr. Chen, I saw this thing that you're doing, but I don't understand what this not taking insurance business is." And you can tell them. And another thing you had done too is you had a series of YouTube videos where you recorded your town hall. So I wanted to
Mm-hmm.
ask about your transition, because in addition to you losing your voice and talking extra at the end of all these visits to tell your patients what you were doing, where in that journey did you decide to do a town hall? And tell us about the town hall. Was it helpful? What, and if it was helpful, how was it helpful to your practice as you transitioned to DPC?
So I'd heard about the town halls from Dr. Hoke and then several of the guests that you had on your podcasts. And we have conference rooms in our building. It's kind of a mixed use office building, and we had space that we could do it. And so I offered that up. Just, I got so many questions over and over and over again. I'm like, okay, let's do this all at one time. I think the first time I had about 25 people show up, and the second time about the same. I think ultimately I did three town halls, and the last one was pretty poorly attended. But I will have to say I did another town hall this past year in the midst of running the DPC, and we had one person show up, but that one person turned into six patients. So it it was, I guess that was a high yield, very small attended high yield meeting. But I would say it was helpful in that the people that attended got very in-depth answers to their questions. As far as volume goes, I don't know that it made a whole lot of difference because it was mostly my patients. They already knew me. They already had access to me in other arenas. If you were in an area that did not have DPC available, you're the first doc in town that's doing that, or you're a part of maybe a different organization like a Rotary Club or something along those lines, that could be very helpful to reach a bigger group of people. But I think if I just put a sign in the yard and said, "Hey, free cookies," and you want to know about DPC, that didn't draw many people that last time.
Now, when you talked earlier about how just the numbers game wasn't really making sense at all for you in terms of in fee for service, you'd have to see more and more and more to maintain the income that you brought in. When you transitioned to DPC, how did you financially plan for DPC so that all those things you had to pay for, your kids' education and their necessities and your mortgage and all the things, how did you plan financially to make the leap into DPC so quickly?
Yeah, it took a lot of math, and even the math was a bit fuzzy, as they say. Until I opted out, and I did opt out from the beginning from Medicare. I worked for an urgent care as well in town that was a multi-site urgent care, and so I just upped my shift work and worked a lot of weekends leading into that to kind of build a bit of a nest egg or a cushion on the cash flow side of things. In the practice, I wasn't initially able to reduce my overhead at the beginning because I essentially was still running a fee for service practice on the business side, trying to clean up all the AR, the accounts receivable. So for the first 3 months, it kind of looked the same, except my DPC membership fees were coming in, and I was getting some insurance payments in from those patients I saw October through December of 22. So that was actually a nice crossover. It didn't make it as stark transition, and it kind of, I'll just say I did not take a paycheck March, April, May, I think, of that first year. And that's where that cushion came in. And my wife also has a good job and we were able to make the cash flow work. Thankfully, we're blessed in that regard. So didn't have to take out a loan, which was a huge blessing. We had the opportunity to had lines of credit for the business that we could have pulled from, but did not have to do that. And then about the time the insurance payments started waning, the payroll part of it, as far as my employee who I was responsible for employees paying their salaries, went down commiserate to my use. And so that part of it helped as well.
Because as you transitioned, and thank you so much for sharing about how financially you transitioned, but was there anything from your time in fee for service that was mentally holding you back from just being completely free in DPC? Like, did you have any habits that you found yourself doing that were like, I actually don't need to do that workflow anymore because that's not needed in an insurance-free world?
Oh, definitely. I probably have couple hundred ICD-10 codes that I have in my head that just automatically regurgitate every time I say a diagnosis. So I don't have to remember those until I refer somebody or fill out a physical therapy referral or whatnot. I don't have to always, did I ask enough review of systems to qualify for a 214, or is this a G code on the Medicare visits? And now I relish, and I don't care. I don't give a flip whether there's a G code or not.
Amen. I just saw a recent post that was like, now you can get paid for this. And I'm like,
Saw
I
that.
literally don't know what this is saying. It's like completely foreign language to me because I had the I don't care air of like in front of my eyes, in front of my glasses. So I'm totally with you. Now, when you got through this first 3 months of closing the book on insurance, being completely free, having your members join your practice, In terms of the admin side of things, did you change? I mean, you told us about your EMR transition in 2016, but what was your experience then choosing things like your tech stack to be able to do DPC without having the burden of coding anymore?
Yeah, so that has been a work in progress, and I have an ideal way things should be, and then I have a way that is feasible for me right now. I'm very much piecemeal right now with all of the components of our practice management. Our EMR is the same one we've had since 2007. Well, I've had since 2007. It's obviously been updated, but it handles scheduling and visit capture and all the all the data that we have to put in, scanning documents in and such.
Now, let me ask you about the after effects of you explaining to your patient panel prior to 2023, this is what I'm doing. It's called direct primary care. I'm still going to be the same Dr. Chun, except I'm going to be able to be more of Dr. Chun than Dr. Coder Chun. When you made the transition to DPC, I mean, your growth has been insane. I mean, you have over 600
Oh, for
patients,
sure.
and this is early of 2024 when we're recording this. So, in terms of the patient's understanding of DPC and what that manifested in terms of number of patients joining your practice, how did the growth happen at your practice? Was it all up front? Has it been consistent until now?
No, it's funny. My graph, I wish I could show you. It's a funny camel hump that I had the pre-enrollment, and I had about 225 people that were enrolled prior to January 1. And then January was another big month because people were like, "Oh crap, is it too late?" So they I think I had a bit of an emotional rush from some of the patients who signed up very early on, scared that they weren't going to have the opportunity later. So by the end of January, it was like 335 or so. So yeah, it was a crazy first couple of months. That has tailed off, and I've been pretty flat on the growth curve since about July or August of last year, of about a net of 15 patients a month since then, which is I anticipate that will continue on. It's been that way now for 6, 7 months.
And in terms of your practice, to be able to spend time with your family, spend time with your wife, spend time with your kids, have you envisioned a cap on the number of patients you'll accept as members at Chun Family Medicine?
I'm ballparking 800. And I know that sounds like a lot, and it's more than what a lot of people say. I had a active patient panel at the transition of over 4,000 patients, and I don't say that in a bragging way. It just is what I tolerated and what I got used to. It's like boiling the frog. And 800 patients right now does not seem. We're right at 695, I think, today, and I can still see 8 to 10 patients a day if I need to. That's not every day, but that's a pretty doable pace. I have a really good MA who takes a lot of workload off of the administrative side of things, and she's definitely worth her weight in gold. And so, with that kind of seasoned process, 800 seems doable. I have told my wife and I've told Amanda, the medical assistant, that once we get to the point that I can't offer same day, next day appointments, or can't get one more prescription sent out in the day or whatnot, that's when we'll cut it off and let things kind of the attrition back it back down to a doable level. But
I think that's great. I think that's so reasonable to say, like, it's not the number, it's the, if I can't provide this level of service, if I'm delving back into the depths of the fee for service cattle call medicine feel for my practice, then that's not what I'm here for. That's when I will put the brakes on. And I think that, especially from physicians who are doing DPC in their third to fifth year, I think, I mean, you're not even there yet, and you're already thinking these thoughts, which I think are very, very important for people to think about. It's reevaluating your practice to see, is this still allowing the fill in the blank that I wanted to have by doing DPC, income, time with family, et cetera, et cetera. I mean, you fill in the blank for what works for you, but I think that that is
right,
really important for people to hear. It's not the number, it's what matters for you and your patient relationship. So awesome.
right. In
Well,
this
now,
season of life too, as an empty nest Doc, I learned too late in life, too late in my career, or later than I would have liked to, that DPC existed. So my kids are out of the house, and I don't have to go to ball games. Have to. I loved going to ball games, but that's not part of my schedule anymore. For me to work until 5:30 or 6 o'clock doesn't ruin the day anymore. So it's a little more tolerable. When the kids were all playing their sports and doing their school activities, it was a tragedy to miss a recital or a ball game, and today I can tolerate a little bit more flexibility.
I think about Dr. Anand Mehta. His youngest is, I believe, in kindergarten or preschool. It's
Mhm.
preschool, and I'm going out to talk with him and other DPC docs in May, and in Atlanta. And he said, "Okay, guys, I might be late because preschool graduation is happening." And we're like, "No, you will not miss your daughter's preschool graduation. Period. Like we will be fine. The world will continue on if you are not present for whatever conversation." And I think that that is something that, especially hearing you say you couldn't take vacation. I mean, we all know those people who you work, 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 and then something bad happens like the day after you retire, cancer, hit by a car, whatever it is. And it is so tragic that we have one life. And I hear you when you're saying you wish you would have heard about this sooner. I think this is also why it's so important you're sharing your story so that other people, no matter where they are in their career, like Dr. Tom White, I think he was 25 years into his career, or the people who are in residency right now hearing this, it's so important to hear from another physician what the journey has been like. So again, super, super grateful for you sharing your story. Now, when it comes to the pricing of your practice, I wanted to ask this because
Mhm.
something when I was scrolling, because I check out everybody's websites, when I was scrolling, you have something that goes beyond just the membership, the monthly membership, unlimited visits, et cetera, et cetera. You have the DPC basic plan. So can you
Mhm.
tell us about what is the DPC basic plan for those who have not visited your website? How did you develop it and how has it been used in your patient panel?
The DPC basic offering came kind of along the way. When I first opened the practice to pre-enrollment, we did not have that as an option, and several of your guests had said we're not making any exceptions. This is a not in a angry way, but just, hey, we've got a product. This is what we're selling, and here's what we're going to offer. And I had so many people. I say so many, but I had more enough to create a trend that said, but I'm just so healthy. I only come in for my physical once a year. Is this really necessary to pay you all year round or pay an annual fee, big annual fee? Because I have a age tiered pricing for that one visit. I said, well, that does make sense. I hear you, and I get that. I think I could probably argue the value of that, but I hear what you're saying. So Andrea, my wife, and I talked about how do we solve this problem? Do we cut out these healthy people who would be awesome patients who we can talk about lifestyle and wellness instead of the drudgery of chronic illness all the time? And so what about cover one or two visits a year, and then they still have access to the texting and all of that? And what does that look like? What are the boundaries of that? So we came up with two visits a year, which I thought that's a physical and a sinus infection or whatever. And then any other visit that needed to happen within the 12-month membership period would be charged at their age appropriate monthly rate. So if you're 45 and your monthly rate $75, you pay $75 for that extra sunburn or poison ivy or whatnot. And it's been very well received. I've had a few people who have pushed the boundaries, and I've said, okay, it's time to pay up, and they're like, oh man. And I've missed a couple that they've been seen 3 times, 4 times, and I didn't realize they were on a basic plan. So I've gotten quote burned on that. But I've also had about 20% who said, you know what, I'm going to come in more often because I need to, or something developed. So I'm going to transition to the unlimited plan. So we just move their plan over, which is super easy and hand. It's a click of a button, and it's so nice.
And let me ask you there for those patients who are like, I completely understand the value now and I want to be a full-fledged member. If they've already paid, it's 3 months in, they've already paid their DPC basic plan for the year. How do you how do you I know you mentioned the button, but just I'm asking this more for like high level envisionment of how do you then handle what they've paid versus what they owe for the membership? Do you just credit their account with what they've already paid up until that point?
You can do that. You can prorate if it's an annual payment. About 20% do an annual payment. The rest do a monthly payment. So it's less than the majority. But you can prorate. You could restart their start date and just start their membership and credit the prorated amount going forward. There are several different ways to do it. I don't. My office manager does a lot of that stuff, so I don't see that most of the time.
In terms of the word of mouth that has manifested from people experiencing your practice through the basic plan, has that also manifested in more patients, similar to that one person who attended your town hall equaled 6 patients joining?
Right. No, yeah, some people they had the sacrificial family member who they sent, you're gonna have a membership, and then if he's okay, the rest of the family's gonna join. So there's some of that. And then there is the my neighbor said this is really cool. And so they sent a neighbor along or whatnot. The word of mouth has definitely been the most bang for your buck. Treat your patients right, and they're going to tell people, and your neighbor's going to go, oh, I had a sinus infection. I called my doctor and got treated the same day. And I walked out of the office with antibiotics. Like, where the heck did that happen? By the way, I texted him the night before to get an appointment, and he told me, so I didn't have to run to the urgent care. So yeah, that customer service there's no substitute for that.
When we talk about customer service with you, we talk about your practice, when we talk about the fact that you're in Cincinnati and there's lots of DPC presence in Cincinnati, you are part of Tri DPC. So can you tell, I think I want to say Dr. Meckley had mentioned this a little bit on
Mhm.
her episode, but for those who have not heard Dr. Meckley's episode, what is Tri DPC and how has that affected Chan Family Medicine DPC?
So TriDPC is a portal or a pathway for employers to connect a insurance plan, some sort of insurance plan, whether it's health sharing or a traditional insurance plan with direct primary care. So essentially carving out primary care from their insurance coverage for employers. And there are doctors in Cincinnati, I believe there are somewhere between 10 and 12 of us here in the Cincinnati area. Tri-state, that's what the tri stands for in the tri-DPC, Indiana, Ohio, and Kentucky. So that those employers have those 12-ish doctors to choose from for their employees. For me, I kind of came in late to the initiation of that. And so this last open enrollment period, I think I picked up about 25 patients out of that. And it's great. They're great people. The patients are great. They have the same questions and the same understanding of DPC as the regular civilian out there. So it's still a lot of education and answering how logistical questions for it. But it's been a really good relationship. Amy Meckley is a great mind in medicine and the business of medicine, the economics of medicine, and she's been a great colleague to work with and mentor. She's taught me a lot.
When you look back at your transition to DPC, for those people who are, but the income is going to be different, or I don't have an MBA, the people who are asking themselves, I don't think I could do this because do I have this skill or that skill? What would you say to that person who is aware of DPC, but is not yet choosing to do DPC?
I would not be scared of DPC solely on the business aspect. If you can pay bills at home and income has to equal your bills, you can figure this part of it out. And if you need help with an office manager or you need an accountant that you can talk to, those are well spent dollars because the medicine comes back. And that's the awesome thing is that you actually like this whole ethos of being a doctor actually comes back, and it's like having a plant cut down at the ground and it sprouts back out. And I talked to another DPC doctor, Dr. Jonas, in Beaver Creek, Ohio, and called him about a problem, and I said, isn't it great that I can actually call a doctor in the middle of the day and have a 20-minute conversation about something clinical and a little bit of friendship discussion and whatnot. And I don't feel like I've just put my schedule behind by an hour by doing that. I regained my professional identity by doing that. So that would be the first thing that I would say is if you feel like you're losing your identity, the dollars don't matter at the end of the day, and they will come if you're really doing the thing that you're passionate about. It cost me the fee for service model, the current national healthcare system cost me, I'm sure, years of my life. I probably would live longer in the zoomed out picture had I not experienced what I experienced. But the pain and anguish that I went through battling that, and mostly in isolation because of myself. Doctors, at least primary care doctors in many settings, don't have a lot of contact with people. We don't have time to have contact. There's no doctor's lounge and outpatient family practice to go hang out with the colleagues and whatnot. So it was a very lonely struggle for me. And this has brought me back to being a human, being an equal with people in my office and just in the world. It sounds overly dramatic probably, but I was one of those people on the verge of burnout and definitely suffering physically and emotionally in the system. Wasn't the only problem that I had in my professional career, but it definitely didn't help. And I'm very grateful for direct primary care and all the things that it brings to my life today.
Thank you so much, Dr. Chen, for joining us today.
Oh, it's been my pleasure. This was like I was like the fanboy on this. I'm like, oh my gosh, I'm able to be on the show. This is great.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Concepcion.